Horse Plus, available through bloodhorse.com, provides exclusive, timely, and unmatched content to subscribers, including Fox Sports, Blood Horse branded weekly programs, a detailed stakes winners section, behind-the-scenes videos from Blood Horse staff, on-demand access to deeper horse statistics, and a $5 monthly credit to equineline.com. Upgrade to Blood Horse Plus today.
Win big with new DRF All Access Past Performances. With one best-in-class product, you now get all three past performance formats. Easily switch between views. Access the most trusted information in horse racing with DRF All Access Past Performances. Go to drf.com and use coupon code 1FREEPP for a free single card today.
Okay, well, good afternoon. My name is Gary Falter with the Jockey Club, and I'd just like to welcome everyone to today's online webinar panel. Now, this is the final panel in our series of 10 panels this year in 2024. And today's webinar, we're going to give you a firsthand look at the surgical procedure of inserting the screw for a condylar fracture. But before we get into that, I'd like to recognize our sponsors, starting with our presenting sponsors. So the presenting sponsors are the Green Group, Bessemer Trust, and Stoll Keenan Ogden. And our panel sponsor today is the Daily Racing Form. And our Q&A sponsor today, and it's been all year, is West Point Thoroughbreds. And our thanks to all the sponsors for their continued support of thoroughbred ownership and helping us offer these webinars at no charge to you. And as you can see, it's a pretty good list of sponsors this year, and we sure do appreciate it. Okay, so let's get started. I'd like to introduce our speaker, Dr. Alan Ruggles. Welcome, Dr. Ruggles.
Thanks, Gary, and I appreciate everyone being here.
Good. So let me give you some background on Dr. Ruggles. He specializes in orthopedic surgery and lameness, and he graduated from the New York State College of Veterinary Medicine at Cornell University in 1987. He completed an internship and residency in large animal surgery at New Bolton Center at the University of Pennsylvania. Dr. Ruggles remained at New Bolton Center until joining the faculty at the Ohio State University in 1992. He joined Rudin Riddle Equine Hospital in Lexington, Kentucky in the March of 1999 and is a partner there at Rudin Riddle. So if you have a question for Dr. Ruggles, please use the Q&A button at the bottom of your Zoom screen. And Dr. Ruggles is going to have some slides to start off with. And if you have a question that relates to any of the slides, go ahead and put it in the Q&A. And we'll pause at the end of going through those slides and answer some questions. And then if there's any other questions after the video, at the end of the panel, we'll answer as many questions as we can. So a condylar fracture, that I suppose that can happen on any racehorse. Is that true, Doctor?
Yeah, it happens not only in racing thoroughbreds, but racing quarter horses and racing standardbreds, yes.
Okay. In fact, the Belmont winner, Arcangelo, was retired after they discovered a condylar fracture. And some of the other top racehorses, I did a little research, I didn't realize this, that also had a similar injury were Maxfield, Nadal, Dunkirk, Notional, and DeFleet Alex are some of the horses that have also had varying degrees of this fracture. So in a moment, we're going to view Dr. Ruggles conducting the surgery on a horse to repair one of these fractures. And during the video, we'll pause and give him time to talk about exactly what he's doing. But before we do that, there's some slides that Dr. Ruggles has put together, and it's going to help explain and kind of set things up so we understand better what the condylar fracture is. So, Dr. Ruggles, why don't you go ahead and if you're going to share your screen, go ahead and do that now if you'd like.
Yep.
And then just kind of step us through these slides and explain this whole injury and what it's all about.
Sure. And so my screen should be shared. Is that correct?
Yes,
Gary?
I can see it.
All right,
Yep.
great. So, yeah, condylar fractures are probably the most common fracture we fix in racehorses. So, for instance, a clinic like ours will do about 130 to 150 fractures a year. and the majority of those fractures will be some manifestation of condylar fracture, and most of them are lateral condylar fractures. And what a condylar fracture really means is a fracture of the fetlock, and I'll show you some slides in a minute that'll make a little more sense. But it's really at the fetlock, or in common parlance, the ankle, and it's the condyles are essentially the part that the phalanx rotates over on the bottom of the cannon bone, which is the third metacarpal bone, which, if you're looking at your wrist, is that longer bone that goes down to your first knuckle. So we have a condyle as well. We just don't race on our right front thoracic limb and fracture it. So, but regardless, most of the fractures are either are relatively mild, and what we mean by that is this is a survey of about 150 horses at our clinic many years ago. But of those horses, 37% were cracks in the bone, but didn't completely go through the bone, meaning from the bottom to break out to the side. And that'll make more sense when you see some of the slides. 30% of those were cracked completely, but the bone hadn't shifted from the parent bone. About a third were fractured completely and had displaced, and this becomes much more important for the long-term prognosis of the horse, which I'll explain over time. Mostly they're in the forelimbs, about 8 out of 10, and about 85% of those are the lateral condyle, which is really what we're going to talk about. But there are other types of condylar fractures that I'll brush on, because it really does matter.
Okay.
For some reason, I'm not advancing.
Oh, next slide. No.
Let's see. Doesn't want to advance. That must be me. Let's go to next. How's that? Okay, well, that worked there.
There you go.
There's this is an example of it. This is the condyle, so the bottom of the cannon bone. Okay, this is the sesamoid bone. This is the first phalanx, or P1 as it's called. And here's the crack in the cannon bone. So it's originating just off to the lateral side of the midline of the bone, and it's coursing up to break out the lateral cortex. But in this case, it's non-displaced and incomplete. And some of those fractures that are very short, let's say it ended right here, some of those can just be rested. But in general, even the short ones, we wind up doing surgery on, because it tends to be much more reliable as far as getting the horse back to training quicker and not having recurrence of a fracture. But that's somewhat trainer and owner preference. But any fracture that was this long, especially if it went to the top of the sesamoid bone, these horses will be reasonably lame, meaning they'll be weight bearing but have a limp, and repairing them with screws immediately when they wake up from anesthesia, they're much more comfortable and they heal quite well. So the longer fractures, even if they're incomplete, we would put screws in. And what you'll see in the video, but I might as well explain it now, the screw is going to glide through this portion of the bone, just like if you were doing woodwork, for instance. Now, my mother was an RN, and when I decided to become an equine orthopedic surgeon, she told me that orthopedic surgeons are only glorified mechanics. But anyway, that's my perspective. And then once we glide through this portion of the bone, meaning we drill a hole the same width as the threads, and then we drill another hole in the parent portion of bone that's the same diameter as the shaft of the screw, and then we actually tap, just like you would in metal, or if you're putting caulks in a horseshoe, we tap it to make the threads in the bone, which are identical or match the threads in the screw. And then once the screw then glides through this portion, the gliding hole engages the parent bone where the threads are. As the screw is tightened, the screw head, which would be compresses the bone.
So could a horse with a fracture of this nature go back into training at some point?
Yes, a horse like this, they're going to have about an 75 to 80% chance to return to training after repair. So quite high. So longer incomplete fractures we fix, and any fracture that's displaced we fix, because those horses need to have the articular surface placed back together, or they become very lame. We do special radiographs. Let's not worry about that too much. I'm trying to move this so I can see. There we go. This is a displaced fracture, so you can see the bone, the fracture has come up and it's broken out. So it's not next to each other, so that becomes displaced. And then we look down here at the joint surface. You see that little pyramid-shaped bone?
Right.
That's actually a separate piece of bone, or what's termed medically comminution. And this becomes important because there's articular cartilage in there. There's this piece of bone could prevent proper reduction. Reduction means putting the pieces of bone back together perfectly, things of that nature. So when we start seeing these become much more important for the horse's long-term athletic function. Doesn't mean that they can't return to racing, but this starts making things harder, if that makes sense. So horses that are cracked like this or displaced, 95% of those had fragments.
Okay.
And then finally, there's two other things to talk about. One is, even though this is a lateral condylar fracture, you can see it comes out and breaks out the outside. It's much more complex because there's fissure lines way up the bone. So this would necessitate additional surgeries with a plate to help counteract those forces to prevent that bone from breaking. So the point of this particular slide is that all condylar fractures are not equal. So when you get the phone call and they say the horse has a condylar fracture, and let's say, you're an owner and you've had 3 lateral non-displaced condylar fractures, and they all got 1 or 2 screws and did great and went back to training, and then the next one you get a phone call, it's a condylar fracture. Well, it turns out it's a medial condylar fracture, or it's displaced, or it's a spiraling fracture. It is a condylar fracture, but now things have changed as far as what's to be done, the outcome, the expense, the time off. So they're not all created equally. And it's just important to know that. And we even get phone calls where the horse will be sent in, presumably for a lateral condylar fracture. And in fact, it's much more complicated. And sometimes the clients aren't so happy when we discuss that.
Sure.
But you need to know what you're dealing with. So sometimes there's pre-existing degenerative disease or arthritic changes, that fragments in the back of the bone, the joint that I talked about with the displaced fractures, additional fissures, what you see here. Sometimes the sesamoid is injured as well. That's very important. And then sometimes the fractures aren't lateral, but they're medial. And why that becomes particularly important is because those fractures can actually break completely the cannon bone. So here's a displaced lateral condylar fracture, but you can see it's got another fracture here in the sesamoid. That's called an axial sesamoid fracture. This would be similar to what Charismatic had in the Belmont. He had a displaced condylar fracture, and then he had an axial sesamoid fracture. And this is very, very important because these are very hard, or I would say essentially impossible to come back to race from, because this bone does not heal very well. The horses can be pasture sound and may be able to do something else, but they're very unlikely to race after this injury.
But breeding sound, if it's a broodmare.
Yeah, it should be breeding sound, exactly. But that's a little bit of work involved, and some of them are lame for a while, so you have to kind of manage them. It's not that simple. And then here would be an example of the complete displaced lateral condylar fracture. It's not very displaced, but it is displaced. There's no axial sesamoid fracture. That's good. It doesn't look like it's got palmar comminution. But on this horse, this is a medial condylar fracture, and these things can be quite dangerous because they course up the bone, and they're sometimes barber pull up the bone, and those horses can actually break their cannon bone essentially in half. So because of that, we have to treat them differently with plating. Now, we just finished the study. It's not published yet, but even with this fracture, we were able to get 70% of the horses back to training with plates, and those plates get removed. So anyway, there's a lot of detail there about the differences, but it does matter. When we see the video, what you're going to see, I'll go through it here. It's essentially what we do is we're making incisions, small incisions to place the screws. We call them stab incisions. So we're not like, this is a great view of the cannon bone, but we're not looking like that because obviously we don't want to do that dissection. So we need to be able to visualize where the cannon bone is. And then we use some radiographic markers, including needles and small drill bits, so that we can ideally get the screws placed in this portion of the bone here, and then if we need a second one above it. So this is just like showing some figures of what's done. So needles are placed, stab incisions made down to the bone, and then we'll go ahead and drill through the fracture line here with that larger drill bit to make the glide hole. But we'll go into this with more detail as we see the video.
So are most of these fractures, you mentioned some of them, the horse would be lame, or some of them you just feel some heat, or the horse is just not walking properly, or most of these you're going to see a difference in their walk?
Most of them are not like a diagnostic dilemma, but you'll know, like if they're displaced, they tend to have swelling. The lameness is certainly present. The non-displaced fractures that are longer are generally fairly lame as well.
Mm-hmm.
The ones that are very short at the very bottom of the cannon bone sometimes don't even show up on the first set of radiographs. So we may isolate the lameness to that portion of the horse's limb using diagnostic anesthesia, meaning nerve blocks, but or using a bone scan and find very marked activity there. But the radiograph will be normal. So if I have a high index of suspicion that a condylar fracture could be there, we'll generally send them home for stall rest and have another set of films done in about a week to 10 days. Because what will happen in that period of time is the diseased bone will get absorbed by the group of cells called osteoclasts. And those osteoclasts essentially start resorbing the damaged bone, and then the fracture line becomes obvious. Because if it's just a crack, you may not physically see it, and you may even miss it on a computed tomography, for instance. So the follow-up films I would say, of the horses I suspect have a condylar fracture, I would say somewhere between 10 and 20% of them wind up having one on the follow-up x-rays. And if that's the case, then they come back in, or if they're local, and we go ahead and place a screw at that point. It doesn't change the outcome.
Okay. And I'd just like to remind the audience, if you have any questions regarding these slides, go ahead and submit them with the Q&A button, and we'll pause before the video and answer some of those questions. Go ahead.
Yeah, I mean, if you want to be board certified in surgery at the end of this lecture, you're going to have to ask some questions. So we're drilling the glide hole, and then once we've done that, we have a sleeve that slides into that hole, and that sleeve is let's pretend this hole is 4.5 millimeters, which is a common screw diameter. Then this sleeve is 4.5 millimeters on the outside. It slides perfectly in there, so there's no wobble. Now the center of that sleeve is 3.2 millimeters, which is the next drill that we put in, which we're showing here, and that drills the thread hole. And the 3.2 is important because that's the same diameter as the shaft of the screw. So then once we've drilled all the way through, then we're going to use a tap to cut the threads. And then we've already determined what size screw we're going to use as far as length goes using a measuring device. You'll see that in the surgery. And then let's say most of these are between 52 and 56 millimeters, just in an average thoroughbred. I mean, we have enough experience to know that, but we still measure. And then we put the appropriate screw in. This particular slide is just showing you, especially in the hind limb, horses tend to be a little cowhocked, so their legs will rotate out. And when they're under anesthesia, you have to take that into account when you're drilling. So if you drill perpendicular to your body, you're not drilling in the right direction. You have to be perpendicular to the bone. But that's why we take the radiographs and things like that. These are just some tips and tricks. These are from slides that I show people how to fix them, which is what we're doing today. So this is actually the horse you're going to see in the video. The slide itself is, I mean, in the video, it's hard to see the screen because it's hard to take a video of another screen. So I'll just show you. This is the fracture line here. These are needles. This needle is placed at the top of the first phalanx in the front of the joint. This is placed just above the sesamoid in the back of the bone, essentially, so that what I do by doing that, I can visualize where I think where the bone is. So I want to go in the center of the bone, not the center of the leg. If that makes sense, because the screw would be in the wrong spot. And then we go ahead and put this marker bit in, and it's not in very far. It's in about 4 millimeters. It's just there to give me guidance. I'm like, okay, I angled this a little bit forward. That's all right, because when I'll correct it by angling a little bit back. It's not supposed to be perfect. But what I do, and what I train my residents to do, is to look at this and say, what do you think it looks like? What do you think the x-ray is going to look like before you see the x-ray? And that helps train your mind how to do it. So here's the marker bit. It's oriented well. it's not angled towards the joint or away from the joint in any significant way. We'll go ahead below it. We put that bit above where I want to put the first screw, so we're aiming for about here. This is a reduction forcep, so it squeezes the bone together before we drill the holes. So everything is held as tightly as possible. And then here are the 2, 4, 5 screws that are placed. Again, it's gliding through this portion of the bone and engaging this portion of the bone. And then when we tighten it, the screw head compresses it. The same thing here. The only difference between this screw and this screw is that in this part of the bone, it's already got a concavity to it. So we don't make a countersink. And if you're familiar with woodworking, if you want to, you don't want to like the screw to sit proud over the bone, over the wood, sorry. So there's actually a device that you use to countersink. Well, we have a similar device, albeit, stainless steel and Swiss made and everything. And then hopefully we've placed these in the correct spot.
And that's the side view of the screws, just
Correct.
the heads of them. Okay, very good.
Yeah. And that's, so they look pretty straight. So, so we're happy with that. This is an example of a displaced fracture. And the importance of that is this is what the joint looks like. Right. So this is the fractured portion. This is the parent portion.
So that gap is the fracture?
Yeah, because it's displaced. So if we just put a screw in here and kept it displaced, you can see this is not ideal. And in fact, the horse would remain lame. And believe it or not, that type of incongruity will put a bending force on the screw every time the horse walks, and the screws will break over time, and they cycle. So screws are great, except they don't like to be bent. They're hard to pull apart, but they don't like to be bent. Like a paper clip, you can't pull it apart very well, but you can bend it. So the same thing happens here. If we don't reduce this well, if there's a defect. Now, sometimes you get a displaced fracture, and it's really hard. Like, I mean, not everything is easy. So you can even think you do a really good job, and they can still fracture later. The screw can fracture later, and you have to do some additional procedures. But anyway, that's what that would look like. And then here's an example of what it looks like when you reduce it. So here's the front of the joint here, and this is the back of the joint here. And so you can see the fracture on both sides. You can see that little Y piece right here, right? So anyway, here we are reducing it. This is the front here. So it's reduced now, and this is the back here. And so everything is reduced well. So we're confident, and we take a radiograph, and we're confident things are in the right spot. Then we put our screws in. So when they're displaced, we always do an arthroscopic procedure at the same time to evaluate the joint, not only for prognosis, but most importantly, to get it reduced well. So we know we have it reduced well before we put the screws in.
Okay. So I've got a couple questions in the queue. Why don't you go ahead, and when you're done here, I'm going to propose those questions. Okay.
Yeah, whatever works. So here's an example of that same horse before the lateral condylar fracture, but then it spirals up. So we need to fix the articular portion, obviously. So we scope it and do all that, but then we have to do something to counteract. These are more important forces. The horse has a risk of completely fracturing his cannon bone in multiple pieces, which is in general an adult horse a fatal complication. So that we neutralize those forces with this longer plate. So we have these screws that I talked about before, which are reducing the joint, and then this neutralization plate that's placed up the leg. And believe it or not, these horses can do very well. The plates are removed for racing. The lower screws aren't. So we would take out all of this after it healed, not the bottom screws. After it healed, we take it out. Usually that's about 3 to 4 months, depends on the horse. And then they get another 30 days out in the paddock, and they go back to train.
Wow, that's amazing. Okay.
Yeah, it's a much bigger deal. And then just that, if you want, I'll just overall in this study, about 75% of the non-displaced fractures raced. The ones that were complete, meaning you had the cartilage injury, is lower. If they had a fragment, then it's lower. But at least 2/3 of the raced at the same or better level. This is an older study, and things are a little bit better now. But regardless, it's a very reasonable thing to pursue, especially if you're dealing with a either incomplete non-displaced or complete non-displaced, most of those horses will do okay. So,
Okay.
So that's about condylar fracture. Then I was going to do a little thing about bone bruising. So I don't know if you want to have some questions now or whatever.
Yeah, let's go ahead and do these two questions. So here's a
Sure.
question that just came in. Does the bone get stronger after it heals from a fracture? So after one of these procedures?
Yeah, it doesn't actually get stronger, but it heals better than soft tissue. So it
Okay.
becomes normal, I would
Okay.
say. I know that's kind of what we're told. I think they told us that as kids so we wouldn't feel bad if we broke our arms. But it's stronger than when it was broken, but it becomes normal with the remaining bone in general.
Okay. Okay. And how long can these screws survive in a horse, presuming that there's no bending?
Yeah, if
Indefinitely?
there's the issue with removal in general would only be if we had to put a plate, which then affects the bending of the bone, um, or there was, unusually, but if there was an infection or something. But the screws will stay in forever. They're low carbon steel. They have very little reactivity. People sometimes have problems, or small animals will have problems with cold sensitivity. That doesn't seem to be a big issue with horses. At least we haven't recognized it, but the screws will stay in forever. Now,
Okay.
in some jurisdictions, some geography, out west in California, there's a tendency to remove the screws, but that's kind of a local bias. We tend not to remove them.
Okay. All
Never
right.
remove them. Yeah.
Okay. So yeah, if you want to segue into bone bruising, because I've heard that term before. I mean, everybody knows what a muscle bruise is, or you bruise your arm, but the whole thought of a bone bruising is
Mhm.
just very, very different. And maybe you can explain what that is and
Yeah.
how long it takes for a horse to heal from a bone bruise.
Yeah. So bone bruising is probably actually the truth is it's not the right term.
Okay.
But if we called it non-adaptive stress remodeling, how many people,
Okay.
everyone would be snoring, right? So it's become the parlance, let's put it that way, right? So you know how words become, um, even though if they're incorrect, they become a word eventually.
Right.
So
Yeah.
so it's kind of the same thing. So bone bruising is really stress remodeling. And so what that means, just in general concepts, we think of bone somewhat inert, but when you really delve down, it's a very biologically active organ. And just think about the growing skeleton, right? We go from a foal to an adult horse. Well, something has to happen, right? So we think of the growth from the growth plates, but then it grows geometrically as well, right? So when let's say you have a 2-year-old and it's only been out in the field. Now we're going to take it and we're going to do different type of activity with it. And it's going to have some speed work, but it's going to be gradually um, increase in training. Well, that bone has to adapt because now it's
Mhm.
doing something different than what it was doing out in the field. Another example is a person that is drafted in the Army when we had a draft and went from being a couch potato to all of a sudden have to train and run a march, 10 miles. Well, they would get problems in their tibias, get shin
Mhm.
splints because their bone wasn't ready to do this. So during this process of adaptive bone remodeling, the geometry of the bone changes. So it puts bone down where it needs to be put down. It resorbs bone where it doesn't need it to be. And this process takes time. And the resorption of bone occurs at a rate of about 50 times faster than the production of bone. So during training, the bone undergoes this stress adaptive remodeling. Well, if you train too much, that skeleton, and I'm not criticizing a trainer because you could train all the horses the same, but maybe that skeleton isn't ready for it. You can cause an accumulation of damaged bone, and it can get to the point where the bone remodeling just completely stops because it's overwhelmed. So maybe back in the day, you would say the horse had two-year-olditis and needed to be turned out, right? So the older trainers really knew what they were doing as well, but they didn't know
Mhm.
why they were doing it per se. So the bone undergoes this stress adaptive remodeling, and if all goes well, then you're able to continue to train. But at certain points, sometimes the bone just shuts down, and we accumulate micro damage in the bone, and this is really a precursor to fracture. Now, many
Mhm.
horses, the vast majority of horses that undergo maladaptive stress remodeling, I mean they're not able to to overcome it during some point in their training, don't fracture. But almost all horses with condylar fracture have some degree of non-adaptive stress remodeling, at least in their history. Okay, not
Okay.
everyone, but so it's a precursor to fracture. We diagnose it usually based on clinical signs, and diagnostic anesthesia, but we do a lot of bone scans and radiographs because many horses will have this happening in multiple limbs. So they might be going crabby behind. They're just not normal because both hind legs hurt them. And when you look at lameness, what you need to see is a difference in the weight bearing. So if you're evenly sore on both hind legs, you might be choppy, like ow, 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 ow. But if you're like very lame in your right, you're going to put more weight on your left, right? So you can see those lamenesses that are asymmetric much more easily than you can see symmetrical lameness. So that's one of the problems, and that's one of the ideas with the sensors in the saddle pads is, do we see a difference in stride length, right? Is there something different about that horse's fingerprint, if you will, that can alert us that the horse is having trouble, even though the lameness may, even to a very experienced owner, trainer, veterinarian, it's hard to pick out. And that happens. Now, there's other stress fractures that are really traumatic, right? But in general, so that's what we're looking for. So here's a bone scan, and you can see the marked uptake of that's what the black is of the radiopharmaceutical, and that's in the condyle here. And this is a side view, and you can see how that really lights up that bone, if you will. This would be a more normal uptake. This is a splint that's active, so you can see the uptake there as well. Some of the things we'll see on the radiograph, obviously we could see a fracture, or we could see these other fractures, which are called palmar metacarpal fractures. So they're kind of like U fractures in the back of the bone. We don't put screws in those, but we can see those cracks as well on a radiograph. So bone scan is really, really helpful to tell us, hey, this is a very specific test for bone remodeling.
Okay.
Yep. So it works pretty well in there. So other things, so here's a bone scan being done. This is the pelvis, obviously we're doing it. In this particular bone scan and radiograph, you can see the uptake here in the tibia, which is where we're pointing right below the stifle. And this horse has a tibial stress fracture. And you can see the callus that's formed there, right? So that's the bad news. The good news is slow horses don't get stress fractures. And they also, if you recognize them early enough, they heal very well. So that's the good news about that. So bone bruising or stress remodeling can have variable lameness. They generally don't have joint swelling. They generally don't have limb swelling. They may or may not have radiographic changes. This one does, but a lot of them don't. Scintigraphy is super helpful for that, as you can see here. The one thing about a bone scan that many people don't know is you need to wait at least a week from the onset of lameness to do the scan, because you need these cells, these osteoblasts, to be present to start healing, do the reparative phase of healing. So if let's say you got acutely injured today and you did the bone scan the next day, it may be negative. It may be a false negative because those cells aren't there. So this is really a functional test.
But you come back a week later and you might see something.
Yeah, you need at least a week to see that. Now, most of the tibial stress fractures are ongoing, and we would see them even if they were acutely lame. The problem's going on. So we use scintigraphy, radiographs, physical exams, really important. We do that on every horse. We block every horse. Computed tomography, we sometimes need to do that, which is CT, and MRI will help us as well. In general, scintigraphy, because that's done standing, you can image the whole horse. It's the least expensive of the other imaging modalities. And then the treatment is rest is essential. Eventually, they need to be at pasture, not in the stall. They may start out with some stall rest or round pen, but we try to get them at least 30, but hopefully more like 45 days out in a paddock rather than standing around. We do screw fixation for fractures present, but if there's about a 90% chance they're going to resolve, providing it's recognized and you give them enough time, which is usually about 2 months, but sometimes longer. But some horses get it more than once, so that's kind of a pain in the butt when you give them the time and then you get them trained down. And so here's an example of fixing, like here's a stress fracture of a cannon bone, which is the sequela to a buck shin. buck shin is a stress remodeling phenomenon. It's just not at the end of the bone. And then this is 60 days later after a screw's placed. And then we drill multiple holes. You can see this is a callus here. See one of the holes I drilled. You can just barely see the fracture in this. At this point, we do take these screws out because they seem to bother them at speed. But we don't
Okay.
take the screws that go side to side. We don't take out. Front to back
Okay.
we do. So I think that's everything I had.
Okay, on your slides. Okay,
Yep.
real good. So that gives us a chance now, if Shannon will go ahead and cue up the surgery video, we'll go through that. And I think we'll just let that play and have you kind of explain things as we go. If you want us to pause, or maybe I might have a spot where I'll just say pause. Let's talk about what you're doing there. And we'll get through that, and then just now that you've kind of set things up nicely, we'll be able to watch the video and understand a little bit better. So so why don't we go ahead and get the video started on the surgery, and we'll take it from there. Okay, so it looks like we have the horse on the table being prepared.
Yeah, so the horse has been induced for anesthesia. There's an endotracheal tube in, and our anesthetist, Lauren's doing the anesthesia. And then our technicians here are clipping the limb, and we're clipping. This horse is only have surgery near its fetlock right here, but we are clipping up to the top of the cannon bone, just for safety.
Okay.
And then we do what we call a rough prep out here. We do the whole prep out here, but this is the first 5 minutes is kind of a gross prep, and then the techs will put caps and masks on and use sterile gloves. You can see Quentin in the back there taking the screws off. Here's the fracture right here on this particular horse.
Okay.
We take
on
the
the
hind
left.
shoes off. Yep.
Okay.
usually
Can you go back to that? Let's go back to that image one more time. There we
Yeah.
go. Okay.
Yeah. So here's this is the same view. This is a flex DP. Sorry. So here's a fracture. It's an incomplete, non-displaced fracture.
Okay.
And so we're going to go ahead and put a screw from here, a glide hole right through here and into the medial condyle. And then we'll put a second screw about the top, a little bit above the top of the sesamoid.
Okay.
Second screw.
Okay. So this is the actual horse you're working on.
Yep.
Very good. Okay.
It's a 2-year-old filly, I believe. It was a filly.
Okay. Okay. Let's keep going.
So we've draped, so we wear separate gloves for draping, and then we take our outer gloves off. This is a horse in the OR. We're going to go ahead and try get our anatomic landmarks with needles. So that needle's in about the top of the sesamoid in the back of the bone, and then the second needle is going to go right at the top of P1. That's what I'm palpating for P1. And then we go ahead and put that second needle in. I get joint fluid. It's bloody because the horse has a fracture. And then from doing many of these, you have, I'm explaining to the intern there that you palpate the certain spot on P1, and you go about a thumb's breadth. My thumb's breadth above that is a good spot for the screw. I was taught that as a resident because the chief surgeon said he always had his thumb with him, so that made sense. I'm drawing where I think the condyle is, visualizing it, and now we're going to make our stab incision on the outside, and then as I go to right at the bottom there, it dips down because it actually falls into the epicondylar fossa, that little concavity I pointed out, and then that's one of our interns there. I'm just letting her feel that. And now we have the glide hole. Now we have the marker bit. And I'm just trying to get it lined up where I think it needs to go. The reduction forces are on there. And then we just put this in just a little bit, not very far.
So this doesn't go all the way in?
No, it's going in about 4 or 5 millimeters.
So is this like pre-drilling the hole?
Well, no, this is just to tell us where we are in the relation to the horse's bone, because we're going to take an x-ray right now. So I'm going to modify where I drill based on where that marker drill bit is, and that drill bit is not important. So now we're taking our radiographs in the room, and we have the image. It's wireless. It comes right up on the monitor directly, and that's our front to back view. You can see
Okay,
the
so just pause for a second.
yeah. So
So,
we have the front
okay,
to back view here, and there's the marker drill bit. There's the one
okay.
needle that's lower.
And what is the clamp there
It's called a
for?
reduction forceps. So
Okay.
it's like it has pincers on both sides, and we're squeezing the bone together because we like it to be as reduced as possible before we make
Ah,
those
okay.
holes. So,
Okay.
and then here's our second. You can see a second needle a little higher on the bone,
Okay. Very
and
good.
what
Yep.
looks like buckles there is on the right side of the screen. That's actually a
Mm-hmm.
drill box that we use to press against. It's where the drill is sterilized in, but it's a nice
Okay.
flat surface. And so that's what you're seeing there. That's not part of the horse or the table.
Okay. Okay. Let's keep going.
So now we have our marker drill bit in, and then we're going to, based on the location, the marker drill bit and my needles, there's the side view they're taking here.
Okay.
We're going to go ahead and look at that. And typically this is aimed a little bit dorsal, which is what I'm pointing out. It's just, it doesn't matter that you just need to know where it is so you make your minor correction, hopefully minor.
Mm-hmm.
And then here's the 4-5. So this is gonna, now I'm drilling the glide hole. Okay.
Okay.
And I'm measuring because I want to make sure I drill across the fracture line, which I've done on some preoperative measurement. So I know how far to go. I'm confirming with my intern. They have to do the math in their head. Anyway, now we're going ahead and I'm palpating the other side, make sure I know where I am. And then based on that marker drill bit, I'm making adjustments.
So
And
now we have the sound muted here. Does this sound like a drill?
it sounds like it's a high pitched sound because it's nitrogen. You see my sleeve?
Yeah.
You see how it billowed? It's nitrogen driven, which
Okay.
it's an air drill. They have battery drills as well. These work really well, these nitrogen drill bits. So now I'm saying, all right, I drilled 22 millimeters or whatever I decided. Maybe it was 25. I can't recall.
Okay.
And I'm just measuring a spot on the drill that now is closer to the drill guide, which is in my left hand. And now I need to go a little bit further. And typically you can feel yourself go across the fracture line. We're cleaning the drill bit to get the swath material out. We're using the saline as a lubricant to prevent heat production because you can really get a lot of heat production, which is dangerous and causes
Okay.
necrosis of the bone. All right, so now I've drilled far enough. I put that centering sleeve in I talked about. So now
Right.
the second hole is perfectly centered on the first hole. And I've drilled all the way through the bone.
So this is just like pre-drilling a 2x4.
Yeah, exactly. Glorified
Okay.
carpentry. Yep,
Yeah.
exactly. So that's a depth
Carpenter.
gauge. That tells us how
Okay.
far the depth is of the hole, or the type of. Now we have to take a little bit off that because we have some soft tissue, but I kind of know what I was going to do anyway. This is the tap, so it fits in the center, the protecting sleeve there, and you have to go forward and back. You see my right index finger going for pressing it. That's a clutch, and it's reversing it. So it's taking that material that we're cutting out of the hole like an elevator.
Okay.
And then those you can see that particular instrument has threads on it. All right, so now I've measured it already. I'm putting I put the screw in, and I put a little screwdriver on top of that screw, just so I know the direction of that first screw. So I want to be parallel if I'm happy with
Yeah.
the first screw, which I was. And now we're going ahead and drilling the glide hole on the second screw.
Okay.
And I asked the person on the front of the horse is my resident, and I said, just make sure my hand is parallel, the instrument's parallel with the first instrument I put in there. And it generally is. See, she's telling me I got to move. But that's
Okay.
okay. That's why you have people, right?
And she may tell you to move a little
Little
forward or
bit,
back.
bring the drill a little bit towards the horse's back.
Okay.
I've drilled the other side. Here's the measuring device. Obviously, we cut some stuff out. We're now
Yeah.
going to tap
Yeah.
the hole. Oh, sorry. I was just checking on the depth of that. That's what it was. I wanted to drill a little bit more. I wasn't 100% sure I went all the way through.
Okay.
I was just double checking that because that's really important. I don't know. Here we are. You might want to back that up. You can see the screw going in better.
Okay. Yeah. Just back it up a little bit. I thought I saw the screw head and everything.
Yeah. You can, if you go back 10 seconds or so. Yeah, that's fine. Just go from there. But you'll see the screw going in. Again, I'm drilling through the other side. I think the next scene, so we'll tap, we countersunk already. And there's the screw going in,
Okay. Yeah.
power drive it, and then we hand tighten at the end. So we use a power driver,
Right.
and then at
And
the end, because you have to be careful you don't over torque it. And then at the end, we use a hand driver.
okay.
And then when you're done, you go back and check all the other screws that you put in already. It's like tightening your lug nuts, right? If one of them is
Sure.
tight, then you have to
Yeah.
go back and check the other ones because they'll loosen. They'll get like this compressive and then relaxation, if you will.
Mm-hmm.
It's a side view. Again, you can't see it very well on a screen, but I showed you those before. And then we suture the subcutaneous tissues here. And then we suture so it's 2-layer closure. And then these are just small. They have maybe 2 or 3 sutures in the skin on each spot. And I think that's when they asked me how I was done already. I said, well, I mean, it takes as long as it takes. So you don't want to take
Yeah.
it.
Right.
I'm sorry, but and this suture is going in the deep
Mhm.
tissue. We're just
So we did edit out a good
yeah.
bit of this. About how long? Okay, go ahead and pause here. About how long would this surgery take from the time you begin back?
From time we started after draping, about 20 minutes.
Okay, all right.
Now, if you're doing a displaced fracture, it could take an hour
Oh,
because
okay,
you have to get it put back together.
sure.
Some of those just pop back in like in literally 2 minutes, and some of them take 30 minutes because you got to take
Okay,
pieces out, and it just depends. Now, if you're plating, you're looking at about an hour and 45 to 2 hours,
okay,
much longer
okay. With the
incision.
plate, sure.
Yeah, a lot, you're putting a total of 16 or 15 to 17 screws in, and you
Hmm.
have a long incision to close. Yeah,
Okay, so
a lot
let's
of
look at
steps.
so this is the finished product.
Yeah, so you can see the 2 screws. The lateral side is to the left. They're gliding
Hmm.
through. If you look to the right of the soft tissue, you see a little debris. That's a little bone debris that you can see on the X-ray. But we can see beyond the screws. There's space still for more screw, which is really good. That means I drilled all the way through and I didn't put too
Hmm.
long a screw in, which is important to know. You don't have
So
to use
that
every millimeter of the bone. There's
so
plenty
if
of
you
bone.
palpate this leg, would you feel that head? Would you feel that screw head
No,
at all?
typically what you'll see is they'll get a lump at the bottom screw head from
Hmm.
the incision.
Okay,
And you might feel the second screw that's higher because it's very little soft tissue, but the first one's actually within the collateral ligament. So
okay,
when we
all
put it
right.
in, we have to spread the collateral ligament with a little hemostat so we don't catch the ligament under the screw
Hmm.
head
Gotcha.
because
Okay.
it'll not compress as well and it might cause some pain.
Okay. So you said this was a 2-year-old filly. What's the prognosis on her? Would she be able to
We should
race
expect her
again?
to go back and race, or go back and train. I don't know what her race record was. Um,
Okay.
this trainer owner, we do a lot of surgery for. I probably do the most surgery of any. I mean, they're my biggest client, I would say, and we
Okay.
expect the horses to, their expectation is the horse should go back, and that's what I told them. I mean, but
Yeah.
you never know, but generally it's true. I don't want to be.
And what would her layup time be after the surgery?
So typically they're going to have 12 to 16 weeks off before they go back to training.
Hmm.
And the earliest time for me is 12 weeks. Some surgeons will bring them back at 8 weeks. I just think they need more time. That depends on how well it's healed. If it was a displaced fracture, it's probably going to be 16 weeks. Their stall rest for 2 weeks for sure.
Right.
And then usually hand walked for another 4 to 6 weeks with stall rest, and radiographs were taken either at 6 or 8 weeks post-op, depending on what I decided. If the radiographs, if it say it's a non-displaced, like 2-screw fracture, we'll probably radiograph it at 6 weeks and say it looks good, hopefully, and then round pen 2 weeks, small paddock for 4 weeks, re-X-ray it if the fracture's healed and the horse is sound, go back to training at that point. Or we may have a program where the 16 weeks, no post-operative injections in the joint. I usually put them on intramuscular PS gag or Adequan, the product I use, but
Hmm.
something like that. They generally don't need joint injections, so we usually
Okay.
don't. They're very comfortable. They get up, the horse recovers typically within an hour of the surgery, they walk back to their stall. If they were if they were, lame walking, they're typically not at all.
Oh, okay. I was going to ask that question. Would she be pretty sound walking back to the
Yeah,
stall?
we walk them up the next morning to take post-op x-rays always. Now, there
Okay.
are, interestingly, with some condylar fractures and some P1 fractures, which is the bone below that, they sometimes go through a period about at 3 to 5 days post-op where they get a little sore. Maybe they've done too much, or maybe it's soft tissue pain. We have to give them a little bute. It doesn't seem to affect them long term, but on occasion you get a horse like that. So I tell clients that,
Okay.
that may happen. Yeah.
So, most of these injuries, do they happen in a race, or do they oftentimes happen in a workout, or
It
is it
typically work out,
50-50?
not usually jogging. So typically a breeze or a race would be and a lot of especially non-displaced fractures, you may not notice anything when the comes back to hopefully the winter circle.
Yeah.
But when they go to the barn and then after they're standing around, usually after you have a bath, and they cool them out, you'll see that often that's time in other injuries as well. P1 fractures, sesamoid fractures, coffin bone fractures. There's a lot of those that maybe it's the adrenaline, the endorphins, or maybe after, we've all had that you do an athletic thing and you don't really notice you have a
Right.
problem until an
Yeah.
hour or two later. It's like, oh yeah, that did hurt, so it's no
Yeah.
different. Yeah.
So you mentioned charismatic. I remember at the end of that race, Chris Antley jumped off the horse and was holding its leg up. I mean, he must have really felt something as
Oh
that
yeah,
horse
well,
finished
that
the
was a
race.
displaced fracture, and so I'm
That
sure he
was.
felt the bobble, or and he pulled the horse up, right? So, yeah, you know what the big, when you get a displaced condylar fracture, the next thing you do is get an axial sesamoid fracture, and then the next thing you do, it becomes dislocated, which is like
Mhm.
very, very serious.
Yeah.
So, that's kind of the progression of things. Now, the other injury, a common thing that we worry about is the sesamoids breaking. And if they do that, then when they weight bear, their fetlock will go to the ground and cause a lot of vascular injury. And that was one of his worries, I'm sure, was that the
Hmm.
horse, may have had that injury. And the safest thing to do is make them non-weight bearing.
Yeah.
So he
Yeah.
did obviously did the right thing for the horse.
Yeah. Just to get the horse pulled up that quickly
Yeah,
and get its
yeah,
leg off the ground as well.
yeah,
Yeah.
100%. Yeah.
Great. Okay. Well, I think this is a good time to take a pause, and we're going to jump into the last of our Q&A session. But before we do so, I want to go through these questions real quick. We're going to hear from our sponsor, West Point Thoroughbreds, on the Q&A, and then we'll be right back. So let's go ahead and hear from West Point Thoroughbreds.
How do you become the gold standard in racing partnerships? One horse, one partner, one victory at a time. Congratulations to all our partners who have made West Point the gold standard for the last 3 decades.
Okay, so here's a question. So how is the displaced bone moved around into place? So if the bone is displaced, how do you move that into place?
Yeah, so we call that a reduction. So anatomic reduction, where we want things to be perfect, and it's really, really important process. A couple ways with the condylar fracture, we manipulate the limb by pushing the foot actually down relative to the leg. I mean, you can't move it too much, and then we flex it and extend it, and that particular motion, while you're pressing on the condyle, often puts it back in position. Alternatively, if that's not working, we sometimes arthroscopically, I'll put an instrument in and I'll press on the bone and try to push it back into place. Or we might have debris there might be little pieces that we have to take out arthroscopically or through a small incision. So there's kind of a multitude ways of doing it, and they're all a little bit different. But that's really it's a manipulation and then pressure would be the answer.
Okay. And this leads into the next question. When there are displaced fragments, do you try to remove all of them?
Yes. So two things. It's a really important question. Yes, if they're free, we absolutely try to remove them. If at the bottom of the bone, when we get those Y fragments, sometimes we can trap, especially the larger ones, we can trap it between the bone with when we repair it and actually keep it in place, like press fit it, if you will. And that's helpful because that's lined with articular cartilage. The pieces at the top that are broken, it doesn't matter because they're not important in the joint. You can discard those and the bone will just heal.
Mhm.
But the pieces on the joint surface are very important. But if they're displaced, like if they're floating around or you can't hold them in place, you don't want to leave it in it because that'd be like leaving a big chip in. And so
Okay.
those are some of the decisions you make that you wish you didn't have to. You can make everything perfect, but you're dealt a hand and you have to deal with it.
Okay. So here's a question. I'm not sure I understand it, but I'm going to ask it. What, if any, is the legitimate role of skin scraping? I'm not even sure about that term.
Um, so I'm not a skin scraper. And I think they mean shin scraping with where you take
Oh,
uh,
shin scraping.
a needle and you go for a horse with a non-adaptive stress remodeling or functions of the third metacarpal bone, and they irritate the periosteum. Um, it doesn't make, in my opinion, and I guess I could get I could be disagreed with, but I don't think I'm wrong. How's that? You can scrape it, and it will cause a periosteal change. But as we understand that what's going on in the bone is we're having essentially that bone right there is like long cables, like on a cable of the Golden Gate Bridge, right? A lot
Hmm.
of wires making that cable, and that bone is called lamellar bone, and it's up and down in the bone, proximal to distal, and that bone is being replaced by new bone, new lamellar bone, and that's happening all within the bone. Like it's not happening. The periosteal portion is a portion of it, but there's way more that's happening there. So I don't. I mean, I think it might just be anecdotally some horses they're going to get better, and maybe they were getting better in the time frame that they had this shin scraping. But I don't see how it makes sense physiologically.
Okay. And how much of this fracture can heal without screws? I mean, can these fractures heal on their own?
Yeah, so a non-displaced fracture, wherever it is, whether I consulted on a Lecrin on an elbow fracture and a horse from another state that the horse is walking and it's cracked, but it's walking and um, until it's uncomfortable, then you can wait. Now in the condylar fractures, I would say if the fracture gets up to halfway or a little more of the sesamoid from top to bottom, like when you're looking at from the bottom,
Hmm.
the most reliable way is to place a screw in it because then you can reliably say in 12 to 16 weeks you're going to be back in training. The problem with not putting the screw in them is some of those horses take a much longer time to heal.
Okay.
So it becomes a pragmatic or practical approach. But to answer the question, many fractures can heal on their own if you're patient enough to let them heal.
Okay.
So that's part of the issue.
So a filly that's about ready to retire could
Oh
just be
yeah, yeah.
retired
So
and
for
you don't even
sure,
have to.
horses that are going to the breeding shed, or like even
Mhm.
sesamoid cracks and things like that. We would not normally fix them, except if the lameness was, there's a welfare issue. Then
Sure.
that would be different. But and I say that because there's a tendency to think that horses that are going to be retired don't need to have things done to them. And I can tell you that's not right because especially carpal injuries, so the wrist or the carpus, they'll get a significant fracture and people say, well, she's just going to be retired. Well, she's going to be way better off. Some of those horses are going to be way better off if you deal with them until
Yeah.
and then all of a sudden she's a stakes winner or she produces a stakes winner and her knee has got terrible arthritis and she needs to be fused, which is
Right.
a huge deal. Um, Rather than just take care of her when you need to be taken care of. But that's a
Sure. Okay. Well, it's
philosophical
quality
view.
of life
But I
then
think it's
too.
important to know as an owner that just because someone tells you the horse is going to be retired, that doesn't necessarily mean that's the best choice is to do nothing. So you
Right.
should ask that question.
Okay. All right. So I think that's going to wrap things up, Dr. Ruggles. So if you have any follow-up questions, audience, for Dr. Ruggles, just send me an email and I'll pass them on to him. Be happy to do that. So just like to thank you, Dr. Ruggles, for your time, the insights. Those images were great. Just watching that surgery, just so educational. I really do appreciate your time. and being here today.
Well, no, I appreciate the opportunity and what the Jockey Club does and represents for the equine industry, the thoroughbred industry. So, but
Okay.
it helps all breeds. You know,
Yeah,
honestly,
that,
the more people are aware of horse welfare and how we should be doing things, the better off the whole equine world is. So, thank you very much.
okay. So I'd also like to thank our audience for being here, especially the owners for investing in our sport, because without owners, we just simply don't have an industry. So appreciate it, owners. And just want to let everybody know we're going to be back in 2025 with another webinar series. I'll be working on those topics here in a little bit. And but until then, we just wish you well, or have an enjoyable holiday and Christmas season. And we hope all of you visit the Winter Circle and you visit it often. Thanks, everyone. Thank you, Dr. Ruggles.
All right, thank you. Happy holidays.
Thank you. Bye-bye.